Please welcome Johanna Derlega, Senior Vice President of National Journal.
Good morning. I'm delighted to welcome you to National Journal's forum, The Future of Medicare, which is brought to us by the Better Medicare Alliance. At this time, I'd just like to ask you to silence your cell phones, but please don't put them away. We encourage you to use social media, and you can use the hashtag NJMedicare. For the Q&A portion of today's events, you can ask a question two ways. One, we have standing mics throughout the room, and you can go ahead and line up. Please state your name and organization if you have a question. And the other is that you can ask a question via Twitter, and you can use the hashtag AskNJ. Finally, if you haven't already, please do download the National Journal Live app. It will provide you information about today's event, our underwriter, as well as our speakers and your fellow attendees. There is also an event survey in the app, and we would love for you to fill that out before you leave today. This morning, we will have a robust discussion on the future of Medicare, a program that is a constant topic of debate in Washington. The upcoming 50th anniversary has reignited the discussion about its future. At the heart of the matter, how to provide the country's aging population with quality and affordable health care while ensuring the financial stability of the Medicare program for future generations. We will now play a short video by the Better Medicare Alliance. National Journal's editorial staff did not have any part in creating this information. Immediately following the video, the Honorable Allison Schwartz, President and Chief Executive Officer of the Better Medicare Alliance, will provide remarks.
I enjoy reading. I love novels. I enjoy doing crossword puzzles.
Well, since I retired, I play golf more, and I joined a bocce league in South Philadelphia.
I'm an ordained deaconess. I sing on the choir, and also we have a school in our church, and I was there for the after-school program, and I taught the children sign language. And all these things because of the Medicare. Well, because of Medicare, I was able to get the best treatment, the best doctors when I had an aneurysm.
Well, Medicare and Medicare Advantage are a great aid in covering your medical costs and your prescription costs.
We always had medical insurance. When my husband and I were working, then I had to stop work because dialysis. When he retired, we lost all of our insurance. We were managing without it, but it wouldn't have been long before we would have been bankrupt. Since I'm eligible for Medicare now, it's been a big help.
When you have to go into a hospital and you're uncertain, it's a strain. It's a strain on your family. It's a strain on you. I get emotional when I think.
If there was no Medicare in my life, I don't think I would be here at this point.
The Medicare Advantage is very important because what would elderly people do?
If Medicare is not there, then I have no access to finding out what the problem is or how to even deal with the problem.
I'm very fortunate and blessed to be able to have this care. I just say, hallelujah, sign language, hallelujah. Happy birthday in English and happy birthday in sign language.
Thank you, Medicare, for all you've done, and a happy 50th birthday.
Have many, 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 many more 50 increments of birthday.
Happy 50th anniversary to Medicare, a program we are all so proud of as Americans. And working together, we can ensure the value and success of Medicare for the next 50 years. Good morning. That is why we're here. So I'm very, very pleased on behalf of the Better Medicare Alliance to say good morning to you. I'm very pleased to be sponsoring this morning's forum on the future of Medicare. And we are delighted to have worked with the National Journal for their efforts to put this together. And we're very pleased to have Julie Rovner as our moderator this morning, and to have Senator Wyden and Representative Brady here, as well as the prominent healthcare thought leaders who are with us this morning. I look forward, as you do, to their remarks. You know, we chose to sponsor this forum because we want to acknowledge the 50th anniversary of Medicare and the successful 50 years of our commitment to Medicare, and also to be able to foster the dialogue that we have to have about how to sustain Medicare for the next 50 years. We and our coalition partners believe that to keep pace with the advances in medicine and the dramatically increasing number of seniors expected over the next 25 years, we do need to be smarter about the way we finance healthcare, and we need to be smarter in the way healthcare is provided in this nation. We're proud of the role that Medicare Advantage plays in providing better Medicare for our beneficiaries and for the seniors and those on disability who are covered under Medicare Advantage. You know, to do this, Medicare Advantage plans focus on prevention and early intervention. They enhance the role of primary care, do better at coordinating care, particularly for those with chronic disease, and really embrace the innovation and technology that can improve communication between providers, settings of care, and patients. Today, Medicare Advantage is offering comprehensive, high-quality, affordable care to 17 million beneficiaries. It is the choice of almost one-third of all those beneficiaries, and is leading the way, we believe, in Medicare for the future. It was so well said in the video, but as you know, Medicare really provides security to seniors that's almost immeasurable. Seniors are enormously grateful for the care that they receive, and they're really especially proud that it's there for them. As a member of Congress and now as the president of Better Medicare Alliance, I hear stories every day about what Medicare and Medicare Advantage means to Americans, how it enables them, Americans from all walks of life, to be able to get the health care that they need. Medicare is a promise that we made, and is a promise that we have kept. And I look forward to the remarks this morning, and maybe even more importantly, I look forward to working with all of you, because together, we are going to work together, I hope, to sustain Medicare for the next generation. And I welcome the panel, and thank you for being here.
Please welcome the Honorable Kevin Brady, Chairman of the Health Subcommittee of the House Ways and Means Committee.
Good morning, everyone. I want to thank the National Journal for holding this important policy forum today, and I really love following Allison Schwartz to the podium. I had the privilege of working with her on the Ways and Means Committee, where she was an early adopter of the need to fix the way we pay our local doctors, was a leader, continue to push in Congress now to make that happen. The truth is we would not have completed that task but for your leadership, Allison. So thank you very much for all of that. Look forward to visiting with Julie Rovner as well as we get to the questions. You know, this week we celebrate, or this month we celebrate the 50th birthday of Medicare, which is such a critical program for more than 50 million Americans, seniors and disabled. If you turn 50, you'll know you really hear three things. From your optimistic friends, they will say, you're not 50, you're 5 perfect tens. From the Joan Rivers of the world, you will hear, it's great to look 50 if you're 60. And Will Rogers maybe said it best when he said, I think the way we could certainly slow down the aging process is make it work its way through Congress, and that would solve it. I don't know what the greeting card for Medicare would be necessarily, but what we need to do, we owe it to those who are on it today to strengthen it, preserve it, and we owe to the younger people, the next generation, to make sure it's in place and ready for them as well. The hard truth is Medicare, the way it's currently financed and structured, just isn't set for the long term. The hospital trust fund, as we know, will become insolvent in a short 15 years. financing for other programs in Medicare face similar strains, and the demographics just are challenging. More and more seniors with fewer and fewer workers to sustain them. So we're going to have to think smart, as Allison said, about how we redesign Medicare for the long term. Truth is, Medicare will not celebrate another 50 years unless Republicans and Democrats work together and act now to save it for the long term. The good news is we've begun to give Medicare a brighter future. Earlier this year, Republicans and Democrats took the first of what I say are 3 key steps to saving Medicare for the long term, and that was solving the way Medicare pays its local doctors. As we knew for a number of years, because of the sustainable growth rate, fewer and fewer doctors locally. We're able to see more and more seniors. And if there's any population that needs to see a doctor they know and who knows them, it's our seniors. And so Republicans and Democrats, in a broad, bipartisan way, found a good, solid solution that really transitions from paying based on volume to paying on value, to rewarding quality, not by the way Washington measures it, by the way our local physicians measure quality. And those are critical improvements. We still have work to do. This bill is really a glide path to a new way, a transition to a new way to reimburse our doctors. We've still got a lot of work to do implementing it. We think there's still better ways to streamline the red tape that our local physicians have to deal with. But that first critical step, and truth is, we cannot save Medicare for the long term unless we took that first step to solve the way we pay our doctors. Step 2 builds off that, and we think with that same broad bipartisan way, and that is to improve the way we reimburse healthcare providers through the rest of Medicare, from the evaluation, testing, and diagnosis leading into the hospital, the inpatient care, the outpatient care, and the care you get leaving the hospital in a post-acute setting, whether it's rehabilitation, skilled nursing homes, a long-term acute care, whatever that is. We believe that the second big step in saving Medicare is to address those issues. Hospital payments, we've laid out a draft last fall to begin the process of how do we align the reimbursements of inpatient and outpatients in hospitals. Today, it's almost a demolition derby of reimbursements, incredibly complex, both for the patient and for the healthcare providers. We think there's a smarter way to go about there. We believe that you can align those incentives toward the patient and doing it in a smart way. We also think in the post-acute care world, there's a smarter way, and so we believe that we can introduce value-based purchasing, rewarding excellence and high quality in the post-acute setting. And again, we really think building on the bipartisan work on how we pay doctors, the bipartisan work on addressing fraud within Medicare, the bipartisan work on Medicare Advantage, we think that there is space to do that. And as we do this, we really are going to face some fairly clear policy choices. And it's really a choice between some of the sort of stale, outdated approaches we've used in the past versus new, fresher 21st century approaches in healthcare. For example, we're going to have a clear choice between more Washington cost controls or more competition that drives choices. We can settle for another raft, another decade of CMS mandates that may or may not work, versus the innovation we know is occurring in healthcare at the local level. Washington can micromanage every medical action, or we can create the incentives for quality care aligned toward that patient, give our providers more freedom to coordinate together, to practice medicine, but also take on more risk to make sure that that is a healthier patient who stays healthy and in the lowest cost setting for them. We know this works. We know the principles of innovation and competition and the right incentives work in Part D, the prescription drug program. We know it works in Medicare Advantage. Our timetable on the Ways and Means Committee, we've begun hearings on a second bill on hospital payment reform. We began hearings on competition and MedPAC recommendations later this morning. We'll be tackling rural disparities in healthcare. We're going to move on to medical education, indirect and graduate medical education, as well as hospital payment reforms, improvements to critical access hospitals. And what my hope is that later this fall we can introduce a package that addresses those issues. So rather than wait another 15 years to take step 2, as it took step 1 to be achieved, we think we need to act now on the second important step. But we have to keep our step. This is Medicare for the midterm. Step 3 is really looking at how we preserve Medicare for the long term. And step 3 is really giving seniors better, smarter choices. For example, simplifying and combining Part A and B with an out-of-pocket cap so seniors have more peace of mind, so they understand how that system works, that we can encourage patient involvement, better prevention, and more open pricing, all of which we think are important to seniors who struggle with a Medicare system that's the equivalent of buying 5 auto insurances for your cars. Between Medicare, Part D, Medicare Advantage, supplemental insurance, all of this, it's the equivalent today of buying a car insurance policy, one for the fender, a second for the engine, a third for the outside of the car, on and on and on. We think there are smarter, simpler ways to provide benefits to seniors. We also believe as Republicans that we need to give seniors more options, more choices. In fact, more personal Medicare for seniors. Some call these premium support. My belief is that this is really Medicare tailored to the seniors rather than to Washington. We envision no changes for those in or near retirement, but an option, a choice for future seniors to be able to pick a plan that's far more tailored to their needs. And as we go about sort of taking the concept of premium support, which has been in our Republican budgets for a number of years, our guiding principles going forward is how do we empower seniors, how do we empower families, and how do we empower doctors and nurses to be able to have the choice of care that, again, rests with them and not necessarily with Washington. So I sincerely hope we can put Medicare on a path to long-term solvency. I'm absolutely convinced, while it's not easy, it's doable. And I think if we set the right culture in Washington, while we may differ broadly on issues like the Affordable Care Act, I think there's actually common ground going forward on how we make sure there is a second 50th birthday celebration for Medicare. Thank you very much.
Please welcome Julie Rovner, Robin Toner Distinguished Fellow at Kaiser Health News.
Good morning.
Morning, Julie.
Thank you for being here.
Sure.
That was a good way, I think, to kick this off. You know, as we approach Medicare's 50th anniversary, I've been covering it for more than half of its existence. I was 12 when I started. But you know, we saw this sort of landmark bill to get rid of what we call in Washington the doc fix, which I think pretty much everybody hated, including the lawmakers, including the reporters. And it was sort of an unprecedented, at least in recent years, bipartisan effort. Is that going to be the exception or the rule? Do you really think that the serious partisan rancor on Medicare has been, if not broken, at least dissipated?
You know, I think it has. In fact, I think, again, that didn't happen overnight. It wasn't easy. It took a lot of starts and steps, and it was frustrating to be reliving that Groundhog Day patch year in and year out. But I think it got to the point where, regardless of what party you were, ideology, we knew we had to solve it. We knew we had to fix it. And I think that drove a lot of it, but a lot of good work. Again, both parties, we had great input from stakeholders in healthcare. And so I actually think that is a model going forward. Again, we're going to go to our corners on the Affordable Care Act. We really see different visions. But on Medicare, and again, we have different visions going forward there too, but we think there's some common ground, especially in step 2, which is reforming that demolition derby of reimbursements, you know, inpatient, outpatient, the way we audit, the way we handle critical access hospitals, how we expand and sort of magnify the power of physicians to deal with all these new populations. They're while those look like challenges, seems to me some great opportunities.
You know, the only thing that's been more a bigger obstacle to, fixing what ails Medicare over the past few years than partisanship has been the sort of what I call provider-on-provider warfare, which is, constantly, it's always sort of a push-pull between doctors and hospitals and physician assistants and nurses and how is there some.
There is some reluctance to do that because because as a whole, we can't save Medicare by writing a blank check on reimbursement. But what we can do is create the right incentives because they matter in Medicare and healthcare in a critical way. And secondly, we can raise reimbursements for those who are providing high quality care. You know what I mean? Who really are focused on that patient, who are coordinating with those coming into the door and where they go when they leave your office or hospital or nursing home. Measuring not, again, I really stress the quality measurements in all healthcare. When it's driven out of Washington, it's just horrible. When it's really driven by what we're seeing happening at the local level, this is good quality care, focused on that patient, often delivered at a lower cost with really high quality outcomes. If we create the right incentives, we can get there.
But I want you to clarify, when you're talking about doing things on the local level, doing things on the national level, where will these sort of quality targets be set?
Well, within the SGR, clearly, we spent a lot of time, Republicans and Democrats, trying to ensure that those quality measurements came from physicians themselves, that we had that pathway to those measurements. Because while Washington may look at 25 metrics and measurement, in truth, the highest quality outcomes we're seeing, the models that are working locally, focus on a much narrower number that really matter. And I think that's really the key going forward. And as we look at post-acute care, as we look at rewarding quality and excellence there and value-based purchasing there, we really ought to focus not, as Medicare has suggested, on 25 metrics, but really on those key metrics. Medicare spending per beneficiary is a good place to start. But there's other apples to apples comparison that we passed in a bill called the Impact Act last year, where for the first time policymakers will really get the data on that post-acute care that allows us to set the right measurements going forward. We just think there's that smarter is better than high volumes of measurements, and there's a way to do it.
Before I go any further, if anybody who's watching this on the live stream would like to ask a question, you can ask a question on Twitter, use the hashtag AskNJ, and I will automatically get them up here. I want to talk about Medicare Advantage for a minute. Obviously, the reports of its demise were premature this time as they were the last time. I think you're seeing more and more people joining because the younger generation is more and more used to managed care. My 87-year-old mother had really no interest in Medicare Advantage because it just, she had all her own doctors. This was the way she'd always gotten care. I think today, people who are turning 65 are used to being in managed care plans because pretty much everybody is. Mm-hmm. How do you go forward and use that as a model to build on while still preserving, or do you even want to preserve an option for fee-for-service?
Yeah, Medicare Advantage, I think, is critical. One, it's clearly the plan of choice for a lot of our seniors, certainly in Texas, but around the country as well. And it's because we've given them freedom to put things that make sense together. In rural communities, Medicare Advantage really matters. I think that's where we sort of unleash more of the innovation, because if we give them more freedom rather than strangle Medicare Advantage, we've got an opportunity to prove out some of these models so that, again, we want proven options for seniors. Medicare Advantage, we think, is the perfect proving ground for that. They have taken, like other health care providers, a huge hit in reimbursements in the Affordable Care Act. I don't think that's really yet shown up. It's just starting to show up in seniors' pocketbooks right now. And so it's really important that Washington not try to slowly financially strangle those options. In fact, that ought to be where we prove out some of the innovative choices seniors can have.
I want to sort of building on that. One of the things about Medicare Advantage is that it's fairly transparent to the consumer. You give up a certain modicum of choice. In exchange, you get certainty on prices, and you get often benefits that the traditional Medicare doesn't offer. How are you going to bring that transparency to the rest of the program? As you mentioned, I may steal that illusion about having to buy insurance for the fender and the door and the steering wheel. Particularly Republicans like to say that patients need to have, be more active consumers, have more skin in the game. But frankly, transparency in healthcare, both in terms of prices and quality, is still in its infancy.
Has to happen. There's no way that we can have, it's fairly easy to have high-quality health care or affordable health care. You can do one or the other pretty easily. Doing both has to be our goal, both in Medicare and throughout health care. You can't get there unless there is open pricing and transparency in health care, unless consumers have real choices, they're rewarded for those choices, they're thinking about those choices, and it's not as easy as it looks because of healthcare, the way it's reimbursed and driven, certainly from the Medicaid side, it's often complex. And so I think the short answer is that our challenge is to create transparency that actually benefits a consumer rather than just sheer numbers. I also think we ought to look, just as within Medicare, as you unlocked and shone a light on, how physicians are paid in Medicare, and then let sort of the free market and others delve into that. I think one of the steps we can look at and take is how we unlock pricing throughout healthcare and Medicare so that we can start putting sort of connecting the dots and giving those seniors actually information they can use. It's a big step. We have to get there. I don't think you tell me, but we don't solve healthcare long-term quality and affordability without that patient engagement.
Well, I've been hearing that for quite a long time. How are you going to sort of overcome this kind of basic disagreement over the long-term changes in Medicare to, essentially from a defined benefit to a defined contribution, putting at risk, putting basically beneficial under most of the Republican budget plans by your committee chairman, Chairman Ryan, they want to put the beneficiaries at risk for rising healthcare costs. Obviously, if they have enough information, they can make smarter choices. Democrats would like to keep Medicare as it has been over its first 49 years and 360 some days, a defined benefit program where you're guaranteed a certain amount of benefits, even though those benefits might not cover everything. That's a pretty fundamental divide. Do you see it closing at all?
Two steps. One, I think taking this second step on improving how we reimburse the other healthcare providers in Medicare, I think it's critical that we take that together to build support for saving it for the long term. We know the sure way to end Medicare as we know it is to do nothing, is to pretend there isn't a problem and just stick with what we know right now. We know that the damage that does to seniors in the not so, frankly, far future, if you think about it. So we know we have to think differently here. We think there's an opportunity to give seniors more choices. They may not all choose them. They may want to stay with Medicare the way it is today, traditional fee-for-service, Medicare Advantage, their choice. But we also think there might be common ground on giving seniors more options, more choices, where they also have more power and more purchasing power, and know that if they do preventative care, if they're engaged, following the doctor's orders, living as healthy a lifestyle as they can, individually, that they're financially rewarded for that. Look, that's where we go in every other part of society. My mom recently passed away. She was in Medicare the old way, and wouldn't be thinking about that. My sons are too young, but I'll tell you, younger people want to be engaged, think differently. Let's give them these options. And I'm also convinced if you spend a lifetime engaged in healthcare, making good choices, rewarded for that, and taking a plan fit for your needs, when it comes to end of life issues, healthy new change.
So you think that's what there's still a lot of back and forth going on about the administration's decision a couple of weeks ago to reimburse for end-of-life discussions?
I think there's only one person that ought to be driving those discussions, and that's the senior. That's the patient who ought to be
I think the idea of it is that the patient, sometimes patients don't know that they need to think about that there are decisions that they can make now that will affect how they're cared for, sort of when the time comes.
Well, I'm sort of hopeful. I follow my mom's lead, who with lung diseases and all that goes with that, made the conscious decision not to spend the end of her life in a hospital. At home with my sister, with our family. She thought through those end-of-life decisions and frankly had such a high quality of life. I'm hopeful I and many others sort of follow that same model.
So Medicare over the years has been sort of the experimental model, if you will, for the rest of the healthcare system, kind of because it's such a dominant payer. What Medicare does, pretty much the rest of the insurance industry tends to fall in line behind. Is that a good thing or a bad thing, and do you hope that that continues?
It's a mixed blessing. There's no question about it. Healthcare is so tailored and so individual and so personal. One of the lessons I've sort of taken away from involvement in healthcare is that you really can't regulate quality healthcare out of Washington, D.C. It's far too complex. And so if Medicare reforms going forward give us a chance to sort of unlock that local healthcare approach, the innovation, the competition, the incentives, then it could be a very good thing for healthcare overall. On the other hand, we know importing, some of the principles of free market, competition, we want providers ferociously competing for our seniors' business, and providing the best quality care at the most affordable price. I think we're going to have to, obviously to save Medicare for the long term, we're going to have to.
Congress tried to do that. It didn't work out very well, which was almost the same sort of trade-off. This was the Medicare Catastrophic Coverage Act of 1997, which you're forgiven if you don't remember because it was repealed in 1998 after the seniors rebelled. I mean, once again, I think seniors and patients in general are not that used to making this kind of trade-off in healthcare. What makes you think that this is going to be any different than that one?
In a healthcare perspective, that was a lifetime ago, in my view. Things have changed so dramatically in this information age. And I think seniors want to understand their Medicare much better. It's become so incredibly complex. One, I think seniors want to know more and be more engaged. Secondly, out-of-pocket costs, are really tough for seniors. You land in a hospital, and every senior's going to, for the most part. Boy, they feel that pinch quickly. And so I think there's real interest in that. The other thing is, and to sort of wrap that up, is that what's your goal? If your goal is just to start with green eye shades, we want to combine A and B so it'll save X amount of money, you started with the wrong goal. The goal is how do we simplify it? How do we make it more informative? How do we actually encourage preventive care, patient involvement, and more choices going forward? If we take that approach, I think there's some common ground here.
And you think seniors are going to be willing to, because obviously, everybody's going to have to pay something probably more, or most people will end up paying a little bit more up front if you do this kind of thing.
Well, combining A and B with an out-of-pocket cost, the only person who won't be interested in this would be a senior who's assured he or she will never, ever go into a hospital, ever. And we know seniors will. And so for those seniors who really want, to sort of blend that payment to make sure they don't get hit with that big ticket item, and they're actually rewarded on preventive care, things they want to be doing to stay healthy, I think that taking that approach, I think seniors are going to have a great interest in that.
Well, good. Thank you very much for joining us.
Julie, thank you. Appreciate it. Thank you very much.
Please welcome the Honorable Ron Wyden, Ranking Member of the Senate Finance Committee. Please welcome the Honorable Ron Wyden, Ranking Member of the Senate Finance Committee.
It's good to be with all of you today. I was told that you were hoping I would talk for about an hour, a little longer. They think I'm serious over there. Their face got all pale. I'm going to be short. We're going to make this a filibuster-free zone because I know we'd like to take some questions. And obviously, these are days to think back about the extraordinary accomplishments of Medicare and Medicaid in the days ahead. My view is that these two programs are among the great steps forward for the American people. More than 100 million Americans now have access to high-quality health care because of these programs. And the creation of Medicare and Medicaid, in effect, slammed the door on the day when older people were warehoused, very often on the outskirts of town in poor farms, and when seniors were the group in America most likely to be living in hardship. Now, as giants in American healthcare, Medicare and Medicaid are going to respond to the big challenges of 2015 that are going to be very different than the challenges of 1965. And without making this one of those late-night shows where you get all the rollicking predictions, I want to give you my sense of 4 major reforms that I see coming down the road in the evolution of Medicare over the next 50 years. First, I believe Medicare and Medicaid are going to lead a revolution in caring for people at home. Nobody who's dealing with a drawn-out illness wants to spend every waking moment in doctors' offices for months on end, in hospitals and long-term care facilities. And the fact is, Medicare and Medicaid cannot afford the costs, especially given the fact that the Medicare program in the years ahead is going to be about chronic disease. And I look back, some of you may know I was director of the Gray Panthers for a number of years before I came to the Congress. I had a full head of hair and rugged good looks. And Medicare was about things like broken ankles. Medicare is not going to be about broken ankles anymore. In fact, I'd venture to say you'd never see another television commercial about Medicare if Medicare was about broken ankles. Today, Medicare is about cancer, it's about diabetes, it's about strokes, it's about Alzheimer's. That's 93% of Medicare costs going to chronic conditions like these. And these are conditions that I believe lend themselves to good quality care at home. And I think Medicare is going to lead this revolution in care for people at home. And the fact is, the alternative is a Medicare level of spending that is just not sustainable. Fortunately, there's been a movement towards home care that offers good quality, high cost effectiveness services. Last month, Medicare announced that one of its innovative cost-saving test programs called Independence at Home is turning out strong results. It is unequivocally saving money, more than $3,000 per patient, as those older people get what they want most out of the healthcare system, which is to be cared for at home where they're most comfortable. House Call Providers is a wonderful program based in my hometown. It's one of the program's early participants. They've been doing extraordinary work for Oregonians for a long time, and they were one of the reasons that I pushed so hard, along with Ed Markey and a number of bipartisan colleagues, to have Independence at Home included in the Affordable Care Act. Just this month, the Congress, both sides of the aisle, which, if you've been watching the last few weeks, can hardly agree to order a Coca-Cola, let alone make major health policy decisions, voted to extend Independence at Home. I think it is evidence, again, that we are on the cusp of a revolution in the healthcare delivery system built around home care services. I also want to mention that Medicaid is going to play an important shift in driving the system towards more home care. The Medicaid program in my home state gives coordinated care organizations the authority to offer services that most people probably don't think are exactly Medicare and medical care at all. Instead of treating the patient for sprained ankles or broken wrists over and over again, they'll visit patients at home and might pay to fix a broken floorboard or a dangerous rug that's causing the seniors to fall again and again. Instead of treating a patient's dehydration every time the temperature spikes, maybe they'll get a modestly priced air conditioner. And you look for mold, or you teach proper nutrition. The fact is, again, there's an opportunity to keep patients, vulnerable patients, out of emergency rooms, out of doctors' offices, getting more care where they want it most. In my judgment, embracing the smart approach to home care makes enormous amount of sense, given the challenges in the days ahead. Hospitals put a lot of work into keeping their facilities clean and safe, and it's a fact that this effort pays off. So as home care becomes more common, our health programs ought to apply those same techniques where patients live. So that is kind of revolution number one. Second, I believe Medicare and Medicaid are going to lead reforms on pharmaceuticals. I believe in the days ahead, the pricing of pharmaceuticals will be connected in some way to the value of treatment. Solving the challenge of skyrocketing drug costs is going to take a lot of hard work, and we're going to have vigorous debate about the challenging choices. But this issue of pharmaceuticals, making sure we can get the cures and people can afford them, is not an issue that can be ducked any longer. Today, pharmaceuticals are curing diseases that were death sentences as recently as a decade ago. Obviously, that's tremendous news for our people. Yet the sticker price for these drugs is often extraordinarily high. And these prices strike many Americans as defying common sense as they increase again and again over time. And the challenge here is obviously going to stretch beyond Medicare, which is why Medicare, with its leading role, is so important in the development of these issues. It was reported last week that Kentucky spent a full 7% of its Medicaid budget on one of two hepatitis C drugs for only 861 people. Medicaid is a lifeline for more than 70 million Americans, but it is not structured, it's not built to handle those kind of skyrocketing costs. Neither is Medicare. And the budgetary experts at the Congressional Budget Office, as you know, have begun to ring some very loud alarm bells. Over the next 10 years, the cost of Medicare D will rise nearly twice as fast as the rest of the program. And the fact is, some of the specialty drugs that have been most sought after by patients are not Medicare D drugs at all. So I want to advance the idea that the status quo is unsustainable. Congress needs to tackle this issue of pharmaceuticals in a bipartisan way. Some of you may know that Senator Grassley and I have sought to do that and are continuing our work. And without it, what we will see is pharmaceutical costs eating up Medicare and Medicaid budgets, wiping out American savings, and we will miss the opportunity to show that it's possible to create the incentives for the bold therapies and cures that the country wants and make it possible for people to be able to pay for those services. Third, I believe Medicare is going to lead the disclosure and the use of health care data. Senator Grassley and I spent years crusading for data transparency in Medicare. That paid off in 2014 as CMS opened up a massive trove of information. The fact is that information is out there. So the next challenge as it relates to healthcare data is making sure this data is user-friendly for the consumer in the country. The good news is that that process, too, has begun. This may be the only place in Washington outside the Health and Human Services building where I can use the word data palooza without generating a lot of groaning and eye-rolling. But my view is that we've got an opportunity to put relevant, useful information about healthcare choices into the hands of typical Americans. Open healthcare data ought to help people figure out which doctors and which long-term care facilities are right for them, or which hospitals or specialists excel in specific areas. And it ought to help show how far a dollar goes with different treatments or providers. I also see open data, and you're going to hear me use that phrase specifically, open data, as a big opportunity to improve healthcare while also providing the opportunity to create high-skill, high-wage jobs in technology. There are a lot of tech-savvy Americans, whether they're here, whether they're in my home state of Oregon, whether they're in Silicon Valley. We've got Americans all across the country who can design smart ways to put user-friendly healthcare data into the hands of the American people. It also, by the way, fits very well into the goal of rewarding care based on its quality instead of quantity. And that also is valuable because if I had a nickel every time I heard a healthcare wonk talking about value-based payments, the Wyden children, 3 of them 7 and under, would never have to worry about paying for college. Fourth, I believe Medicare is going to lead the debate on improving end-of-life care. And I believe all the roads here are headed towards giving patients more choice and a better quality of life when they're suffering in the advanced stages of terminal illness. Too many of our people have faced the impossible choice of when to cut off treatment and enter hospice care. So just last week, Medicare announced that it's going to expand a program that I authored called the Care Choices Model, that's all about putting patients and families in the driver's seat with respect to end-of-life care. Care Choices is going to ensure that patients have the flexibility to continue treatment after they've gone into hospice. And when I pushed for this program back in the debate about the Affordable Care Act, you might remember there were certain people, their names will not be mentioned, were shouting about death panels, and the grandmothers of America had to be on alert because people were, quote, pulling the plug. Fortunately, some of that hyperbole has quieted down. End of life is a painful, difficult issue combining religion and ethics and personal beliefs. But I now believe that patients and families are going to be in the driver's seat on end-of-life care with more choices, and the concurrent care legislation that says for the first time patients would not have to give up the prospect of curative care in order to get the hospice benefit is going to be the kind of program, the type of program that's going to lead the way. I'm going to wrap up with this. I think that those four developments reflect important ways in which Medicare is going to evolve in the years ahead. But there are going to be other, I think, areas to watch, and I'll just mention two in wrapping up. Section 1332 of the Affordable Care Act is not exactly a phrase that is on the lips of everybody in America at dinner time. But this is going to be an important part of the debate about health care services, because what it says is, starting in 2017, any state that can, they believe, can meet the targets of the Affordable Care Act can go off and do its own thing. And I included it in the Affordable Care Act simply because after watching officials in my state, and sometimes I'm called the Democrat from waiver because we believe so strongly in trying our own approaches, they said, let's make it possible for the states to have a wide berth for innovation. And Section 1332 says if you can meet the coverage standards, the various major criteria in the Affordable Care Act, a state can go do its own thing. And suffice it to say, I think that is another area to watch. And by way of wrapping up, what the future of Medicare and Medicaid is going to be all about is the patient. In other words, we have lots of debates. I'm looking around the room and I see leaders of provider organizations and think tanks and a variety of groups that spend a great deal of time and thoughtful analysis looking at the future of healthcare. But at the end of the day, it's really about the patient. And for example, Medicare today still does not guarantee catastrophic coverage. That's going to have to change. Millions of Americans have that benefit in the private sector. So this is an area where Medicare, in particular, is playing catch-up ball. And it ought to, because at the end of the day, it's all about the patient. And I can tell you, having worked in this field since the days, as I said, when I was director of the Gray Panthers, we've come an enormous way. Back when we were starting the Gray Panthers, it was a big deal. If a town had a lunch program for older people, everybody said, oh my goodness, wow, we're really out in front there in caring for seniors. So we've made an enormous amount of progress over these 50 years. Now, as we celebrate this anniversary, I think we have an opportunity, as I've tried to do with several issues today, to talk about how we can make the 100th anniversary of Medicare and Medicaid as celebratory as this one. Thank you for having me, and look forward to working with you as part of that discussion.
Please welcome back Julie Rovner, Robin Toner Distinguished Fellow at Kaiser Health News.
I'm going to start by asking you the same question I asked Chairman Brady, which is that the Medicare doc fee legislation proves that there is such a thing as bipartisan health legislation in Congress. Is that a sign of things to come, or is it a one-off?
I do not think it's a one-off. I'm very pleased that Chairman Hatch has worked closely with me on the chronic care efforts and the legislation we're working on in the Finance Committee. We've announced that we're going to have a bill by the end of the year on the issue that I think is going to drive the future of Medicare. We've got two very good senators, Senator Isaacson and Senator Warner, certainly a bipartisan duo leading this. And I do think that even though the headlines go to the partisanship, behind the scenes there's a big group of senators that are pursuing these issues in a bipartisan fashion. I understand that the partisan issues get the press. For example, on Sunday, for the 1800th gazillion time, we had a vote in the Senate, and I don't know how many votes we've had in the House and the Senate on repealing Obamacare. And I just got up and said, I've spent most of my time in public service working in a bipartisan way on health issues. And Chairman Hatch was in one seat, Senator Alexander was in another seat, and I pointed at Senator Alexander, sponsor of the Healthy Americans Act and the like. And I said, I hope we can get back to it. But then we had a vote on repealing the Affordable Care Act.
On the highway bill.
On the highway bill. You repeal the Affordable Care Act, folks. Make no mistake about what's going on. You take America back to the days when health care was for the healthy and wealthy. Because at that precise moment, you get rid of the protection that people have against discrimination for pre-existing conditions. And then if you're healthy, no sweat. If you're wealthy, you pay. But those are the implications for health policy that's done in a partisan way. And that's probably a longer answer than you wanted, Julie, but it's hugely important. And I do not think that the change in doctor reimbursement is a one-off. I think there really is a lot more going on that's encouraging this bipartisan.
You've been at this a long time. I know that because I've been at this a long time with you. How confident are you that Medicare is going to still be around to celebrate its 100th anniversary?
Very. And that's because, and that's what I tried to do, and I thought a lot about it. I was very pleased to get this invitation to come over to think about what are some of these driving forces that you ought to watch as Medicare goes into the next 50 years. I mean, the revolution around home care and pharmaceuticals is essential because the current path is unsustainable. The current path really raises a challenge that would make it hard for Medicare and Medicaid to deal with its other priorities. Now, I think we're up to it. I mean, we've been up to it in the past. We did have this breakthrough on SGR. You've got legislators wanting to work in a bipartisan way, but I think on issues like home care and pharmaceuticals, the decisions we make in the next few years are going to tell a lot about that wonderful celebration they'll be having 50 years from now.
Well, let me ask you about pharmaceuticals, since you brought it up and since you talked about it. Clearly there we have, as I wrote down, these super helpful but super high cost pharmaceuticals. And we're about to see another very expensive cholesterol drug on the market, perhaps a breakthrough Alzheimer's drug. At some point, does Medicare simply have to start negotiating drug prices? And if not Medicare, then who?
Well, I have voted repeatedly to lift the restriction. And in fact, I offered it the last time it was offered on the floor of the Senate and pointed out
You should probably explain what the restriction is.
Yeah, the restriction, for those of you that may not be up on all the nuances of this decade-long debate, Medicare is barred from negotiating the prices on pharmaceuticals. This is actually a statutory restriction. So everybody else, if you're in the private sector, goes out and negotiates. Medicare is barred by law from doing it. And as one senior told me at a town hall meeting in Oregon, I have these meetings in all these Oregon counties every year, said nobody go to Costco and buy toilet paper one roll at a time. You use your bargaining, power. So Medicare has been barred from doing that, and that's why I mentioned what I think is the next debate on this topic, and that's securing value for these prices. And I'm not sure how it's going to play out. I do know, as I touched on in my talk, the American people want these exciting cures and therapies. We'll listen to the news one day and there are treatments and cures giving opportunities to youngsters to have a full and satisfying life that nobody could have dreamed about 10 years ago. There were death sentences 10 years ago. So we want the cures and we want the remedies. We also want to make sure people can afford them. So I think one opportunity for bipartisanship in this area, and I think we ought to have a big debate about it, and we ought to probably try to lower the decibel level and see if we can have a thoughtful discussion about it, is, as I touched on in my comments, linking the prices to treatment value.
And with that, in terms of something like, the Hep C drugs cure Hep C, that's obviously a fairly high value. Then you've got a big cholesterol drug, which for the people that really need it will be a big help. But
well, I'm not going to jump the shark on Hep C and Sovaldi. Senator Grassley and I are continuing our work on Sovaldi and those issues. In fact, we've had a number of conversations in the last couple of days, but I'm not going to jump the shark. We agreed that we were not going to be commenting on our work until it was completed. I do think that the Sovaldi discussion from various interest groups and organizations is sort of a preview of what's to come. Those who are in effect sponsoring the drug and feel most strongly say, look, it's a cure. This is what you get for a cure, as opposed to having repeated hospital visits, treatments, and the like. Fair point. Ought to be part of the debate. And that's why I've tried to outline this morning and gave some thought with respect to how I think you introduce the debate, because I haven't said this before. I think we ought to have a debate with respect to pharmaceuticals, given the fact we want the cures and we want people to be able to afford them, to start talking about value, the value of the treatment, which, as I noted, is also a big part of health reform generally.
you've got a bipartisan innovation bill on the way to the floor. Is that a possible place to, that would seem to be a logical place to have this debate.
You're talking about the legislation?
The 21st Century Cures Act.
And I think the way I'll leave it, I've talked to Senator Murray about this, and I think we've got a very good, again, bipartisan team in Senator Murray and the chair, Senator Alexander. I think they're talking about the end of the year, and I'm not going to front run them either.
Okay. Well, I want to talk about another sort of big issue that threatens, if not Medicare in general, then Medicare and Medicaid, and that's long-term care. I think as this generation ages, they have less money set aside than their parents did because nobody has a defined pension anymore. And yet the cost of long-term care continues to skyrocket. I remember back in the late 80s and early 90s when everybody said we got to do something about long-term care because the baby boomers are going to start retiring in 2010. Well, now it's 2015. The baby boomers are starting to retire. Most of them need long-term care services yet. But that's something that seems to be never spoken of. We talk about end-of-life care, we talk about lots of other things, but we don't talk about this need to do something about the bill for long-term care.
Julie, one of the reasons that I started with the kind of prospects for what I call this revolution in home care is that this is probably the best platform for getting into long-term care. If you look at the two areas that I mentioned specifically, Medicare, independence at home. First time the program is paying for those kinds of services, and it is really paying off. There have been other governmental efforts that have shown good results as well. I could have touched on the VA, didn't do that. So the point is, Medicare is already showing real promise towards a role for services at home in terms of long-term care. Same is true with respect to Medicaid, which plays a broader role, as you know, because it covers a variety of services and is a critical part of the delivery system. But both programs, Medicare and Medicaid, not because we stood up and said, oh, today we have a huge bill like the Class Act, which, as you know, was a source of considerable disappointment because it couldn't make the numbers, work. This approach, I think, is going to grow out of specific initiatives in Medicare and Medicaid. Medicare starting with services at home, Medicaid with a broader role, but both of them, in effect, moving us towards a long-term care policy for our country at a time when 10,000 people turn 65 every day, that's going to be built around an expanded role for in-home services.
I'm going to ask another question in a second, but we are going to actually go to the audience for questions this time. I apologize, we were supposed to with the chairman too.
Softball was welcome.
Whatever you want. There are microphones on either side of the room. You can line up, and if you are not in the room but you want to ask a question, you can tweet a question using the hashtag AskNJ. I want to talk a little bit about Medicare's place in the healthcare system. I asked this at the chairman too, that Medicare's traditionally been a leader in, the innovations that Medicare has tend to be picked up by the rest of the health insurance system. Is that something that should continue? I mean, it's certainly a place to experiment, and I think the theory is what works for seniors who are arguably more expensive should work for those who are less expensive. Is that something that you think lawmakers should really accept and look at and know that that's going to happen, or perhaps should they be bifurcated a little bit?
I think we know that a lot, and it's why I touched, for example, on what Senator Grassley and I were doing with respect to getting disclosure of practice patterns and physician fees and the like. There, you knew that what Medicare was doing would have huge ripples through the private sector. In effect, what happens when Medicare makes that kind of data, available, people in the private sector, go to their congressperson and say, I want that same deal. Why am I not getting that same deal? And suffice it to say, that's using Medicare's role as a major purchaser of health care in a fashion that helps people on Medicare, but also helps people in the private sector. Now, there are some areas where I think we've just touched the surface with respect to the potential. I think that Medicare ought to be leading more aggressively in the area of prevention. As you know, seniors get a free physical under Medicare. Thank you, Affordable Care Act. But as far as I can tell, for too many seniors, when they get those results, we're spending $4 billion, I think, over the 10-year window on it. They get those results, and if the results are good, then the senior can go to the Dairy Queen and have 3 or 4 hot fudge sundaes. If the results aren't so good, then I guess people may go to a tavern and drink something else. But the point is, we ought to be doing more. So Senator Rob Portman, he's the Republican from Ohio, he and I have introduced the Medicare Better Health Rewards program, where for the first time, when seniors save Medicare money by adopting these important prevention measures, lowering cholesterol, blood pressure, smoking cessation, they would get to share in the savings. Now, the reality is nobody's going to get to go buy a condo in Hawaii with these savings. But as the Cleveland Clinic and the Oregon Health Sciences Center have found, modest savings can make a real difference in terms of behavior. So yes, I think there are plenty of opportunities for Medicare to lead in the future.
And sort of building off of that, I mean, obviously the value not volume is the buzzword of the 2000s. And obviously changing the incentives for patients, changing the incentives for doctors, changing the incentives for hospitals, which means having fewer patients in the hospital, are all big parts of this, and I think an area of bipartisan agreement that everybody agrees that Medicare should work to, and yet most of the experiments sort of trying this out have had mixed results, if any. Is there is there anything sort of on the horizon that can make us sort of feel better about being able to describe and pay for value?
Well, first of all, I think parts of the country where this is new are obviously going to take more time. We like to say in Oregon and Washington with our programs, we were for ACOs before it was cool. You know, we basically had that kind of coordinated care for over a quarter century. So I think you've got a number of leaders, you know, in the field, and you've got, you know, programs like Geisinger and others with warranties and things of this nature. So I think it's going to take a while to get acclimated. Even in my state, where Minnesota and Oregon, I believe, have the highest percentage of seniors in MA in the country, we still, outside the metropolitan area, have most of our older people in these clunky, volume-driven, fee-for-service programs. We're starting to make changes in that area as well. So I think that what you're referring to in terms of the mixed results is a fair assessment, particularly if you incorporate most of the country, which is still getting its arms around this. I mean, in much of the country, just from the standpoint of a cultural orientation towards healthcare, this is dramatic stuff. In much of the country, if a senior doesn't feel well in the morning and their son, you know, has a job with some flexibility, they call up and Johnny says, "Ma, I'll take you to the doctor." That's different than what we might have in our part of the world, where you have, you know, consultation with people calling and people on the phone and the like. So I think it's a little early for parts of the country that haven't had this to start seeing dramatic results this soon.
Someone once said it's a big ship, it's hard to churn.
Yeah.
I think we're going to go to the audience. I think we have a question up here. Could you tell us who you are first?
I'm Dr. Caroline Poplin. I'm a primary care physician. And my question is about the home services, which I think is a great idea. There are sort of two models. There's the private sector model, where some company hires a whole bunch of unskilled laborers, gives them a one-week course in how to take care of people at home, no benefits, no vacations, no training, nothing, not even health care. And there's sort of the Visiting Nurse Association model. I'm not sure how VNA works now, but when I was in practice, they were highly trained, nonprofit, with good jobs, with good benefits, and a way to advance. Are you setting up, or are you considering under your home benefits program these two models? Do you prefer one over the other, or are you just going to let the market sort of determine?
I'm sure you're not going to be flabbergasted to hear I like the second model a whole lot better.
Me too.
Than the first. I mean, obviously, this is a basic fairness for workers, you know, issue. When you're putting in this kind of day with this level of stress that's both physically and mentally, you know,
right,
challenging, you deserve a good wage and you deserve, you know, real benefits. Obviously, this is going to take some time to kind of shake out in terms of how this plays out. My hope always is that the leaders in the field will adopt the second model, and that will drive the market, you know, place. But obviously, there are areas where the market doesn't work, and you've got to ensure that there's fairness, which is why we have, for example, efforts led by Senator Murray and others to raise the minimum wage in the United States Senate. So I certainly like the second model better. My hope is, as is always the case, that sort of the gold standard, you know, employers will kind of lead the marketplace, and everybody else will see that they've got to do it or they won't be able to get the kind of workers. There are instances, of course, where the market doesn't work, and that's why I support measures, for example, like Senator Murray's and others that make sure that as a matter of basic fairness, people who are putting in the kind of toil that you're talking about have enough to pay the rent and gas for the car and a little bit for retirement and food.
And you want to make sure that the first model doesn't undercut the second.
You're being way too logical.
Thank you.
Is there another question, or are you guys just standing there? I have a question from Twitter that says, Senator, with 20 million seniors with obesity costing Medicare $50 billion annually, shouldn't Medicare cover obesity treatment?
Well, the question again about should Medicare cover, X, that's got to be part of a debate in terms of where this program ought to go. It's why I mentioned the importance of prevention and that I am part of a bipartisan, effort here. Look, the reality is I cannot pass a law that says thou shalt not eat, such and such, and I wouldn't want to do that. This is a free country. So I'm willing to have that debate about what kind of services ought to be part of a Medicare package and what the person on Twitter commented on. I will tell you that I think the broadest possible way in which we address issues like that is create more incentives for prevention and good health. I mean, the reality is until Medicare started the free physical, Medicare really was mostly sick care. We waited, I remember this from my Gray Panther days when we had this very same debate. We waited until somebody was really sick, went to the hospital emergency room, and they were getting services in the hospital under Part A. And we said, of course we have to care for them. That's what we do in a country that believes in not leaving sick people behind. But Medicare Part A would pay these huge checks for hospital expenses, and Medicare Part B would pay essentially nothing for prevention. So we have begun to inch prevention out on the field with the free physical, but obviously the bipartisan legislation I described is the next step, and I am very open to having the debate that reflects what we just heard on Twitter, because I think that is a legitimate one. Now, we did see good news here a couple of days ago where for the first time, it was on the front pages of the papers, it looked like we were making real headway in terms of diet and eating healthier, and that's going to factor in the debate too.
And in 60 years, there won't be as many obese people on Medicare. We'll probably have some other problem. But there are a number of things that I think when I'm at that age where friends and associates are turning 65 and getting on Medicare, and they are shocked at the things that Medicare doesn't cover. Hearing care, foot care, eye care, dental care. Do we need sort of a Part E for, coverage of everything that Medicare doesn't?
Well, obviously there is enormous interest in these kinds of services, and it fits once again into this debate that I touched on with respect to why we really need some bipartisanship to walk the Congress and walk the country through these, tough issues. These are difficult questions. Oregon started this with Medicaid years and years ago.
I'm not sure Congress wants to open itself up to that particular debate.
Having said that, one of the reasons that I'm focused on areas where you can give people good quality health care and reduce the costs is to the extent that you can stabilize costs in some of these expensive areas like chronic disease. That frees up money in order to potentially have these kinds of added services. And look, anybody who pretends there aren't choices to make in American healthcare is not being straight with the American people. There are choices to make. I always am amused when you see an advertisement for a health package. We cover everything. We cover everything. Well, the reality is nobody can cover, everything, because if you buy on Tuesday that your particular health plan or your health package covers everything, you better expect on Wednesday or Thursday the introduction of a new product. And then people often call my office because they say, I was told it covers everything. I heard about on CNN X, Y, and Z. Am I covered on that? Where do I go to get that particular device or therapy and the like? So it is by nature of the healthcare imagination and creativity, it is, quote, impossible to cover everything. So the question is, and I'm not saying we should all do what Oregon did decades ago. We either make those choices as Americans and legislators trying to walk through what the opportunities are, or we sort of have them made in the back door when you run out of money. And last weekend or so, I think I had my 740th town hall meeting. And people said, what do you do these things for? You come and a lot of us get mad at you and all the rest. I said, the reason I do it is because this is how I think we can best make difficult, choices. And we either make them in town hall meetings and congressional debates and other kinds of places where people can, weigh in, or in healthcare, they're going to be made in the back door when you basically just run out of money. And we've had that happen, as you know, where people run out of money. We've had lotteries, as incredible as it sounds, for people to get healthcare services.
In your state. Well, on that not so happy note, I'm sorry, we're out of time.
The happy note is we're celebrating an extraordinary run for Medicare and Medicaid. 50 years from the days when a lot of seniors, and it was a moral blot on our country, that we had these poor farms. I've driven by some of them. This was a moral blot on America. And now we have, as Julie noted, a lot of older people living longer, healthier, and happier lives. The kinds of trends I described today allow us to build on it. My final prediction is people are going to be around celebrating Medicare at 100. We're also going to have a lot to celebrate. Thanks for having me.
Thank you.
Please welcome Chris Jennings, founder and president, Jennings Policy Strategies, Inc., Joe Baker, president of the Medicare Rights Center, Rick Pollock, executive vice president of advocacy and public policy of American Hospital Association, Dr. Andrew Gorman, president-elect of the American Medical Association, Dr. Joseph Antos, Wilson H. Taylor Scholar in Healthcare and Retirement Policy at American Enterprise Institute.
I have to change my questions. Give me a second. Thank you all for being here. I think most of you have been doing this for a good deal of time. So I wanted to use this panel as a way to kind of reflect on where we've been and where we are going. And I think sort of the way you're sitting is kind of the way I have my questions laid out. Before we start, I want to ask if anybody has anything in particular that they want to respond to that was said by Chairman Brady or Senator Wyden.
I think one of the things that I was encouraged to hear, certainly from Chairman Brady, is his talk about simplification of the Medicare program and combining Part A and Part B, and looking at an out-of-pocket maximum in the traditional Medicare program, and not doing so with a green eye shade, but really looking at it for simplification. I think, as you said, Julie, certainly there are winners and losers there regardless of how it's constructed. But of course, if you use a very high deductible, combined deductible, you can sock it to people with Medicare. If you calibrate that more, we have less losers and more winners, and get more out of that package. So I was glad to hear that, because I think there could be some movement on that if we really look at it, substantively and protect beneficiaries.
I would just say not to lose sight of why we're here, which is the 50th celebration of a program that's provided financial security to so many, that's helped the disabled and the chronically ill, and that's been a driver of innovation. And regardless of what side people are on the aisle, the commitment not only to the program as it is today, but to the future and ensuring that it is around.
I think it was very refreshing to hear, and we need to be reminded, it's about the patient. That's why we're here. That's what all of this is about.
It's 50 years in the past. It's the 50 years in the future I'm worried about.
Which I suspect is the main reason we're here.
Yeah.
Chris?
Well, Joe's always the downer at the birthday party. But It is. I agree with Rick. He's got my talking points. It truly is something worth celebrating. 50 years of an incredibly successful program that made the difference in people's lives. And not just Medicare, of course, but the Medicaid program, too. It's not the stepchild. It's a very happy, I know we're celebrating Medicare, but Senator Wyden and his staff would be mad at me if I didn't say that. So, and I also believe it very strongly. But I think Joe is right that it's time to talk a little bit about the challenges that face the program. And I would say with every challenge, of course, is an opportunity for improvement and strengthening the program, and I think we should embrace that. The only thing I would really make a point of is that, frequently we don't reflect back on the last 5 years about what has even happened now, and the projections of the Medicare program are far, far below cost growth projections when CBO had projected back in 2010 by magnitudes of hundreds of billions of dollars. And we're now growing at a per capita growth rate of less than 2%, which if we could do that forever, the debate no longer is really, is cost out of control? It's can you sustain success? And I want to talk a little bit about that.
All right, well, first I have a political question for you, and I'll let the rest of you answer. But, one of the things that has marked Medicare's 50 years, in addition to providing health care and security to a lot of people, is both Democrats and Republicans using proposed cuts in the program as a political cudgel against the other. In the 1990s, we kind of famously had the meta scare when the Republicans were trying to do their partisan budget, balanced budget that didn't quite happen. And the Democrats were hitting them for it. And then, of course, the tables got turned in 2010 when the Affordable Care Act had $700-some-odd billion in spending cuts for Medicare, and the Republicans went out and used that to basically regain the House. Is there a way to get that, or will this be ever with us now that Medicare is sort of a big, important political issue? Is it always going to be, wielded as a weapon?
I think there's always that risk, certainly in a political world, and I would be naive to suggest that's not the case. But I do note, for the record, that when in the most recent elections, when Republicans said that there were incredible savings and cuts in the program, and we're going to go back and we're going to repeal the law and we're going to fix that, that has not happened, nor will it ever. Even the repeal and replace legislation doesn't eliminate the savings or the benefit improvements in the Medicare program. And of course, you can look back in Medicare Part D as well. After there was a big Democratic pushback on Part D, the program, I would say, delivered and even exceeded some projections at the time. And we haven't seen any type of efforts to substantially curtail or alter that. So I would say, yes, there'll always be politics. But frankly, I think now Medicare is safer. And in fact, if I had to say who's the least safe, it would not be Medicare. It would probably be Medicaid or ACA funding. And since you have different pots to go after, I suspect that that's going to be the more political appealing target for a lot of people.
As a practical matter, as long as Medicare and Medicaid is 25% of all federal spending, it becomes a part of the discussion every time there's a fiscal cliff, anytime there's anything related to the federal budget. From the perspective of providers serving patients and communities, one of the things we are always concerned about is predictability, because you go from 1 month or one fiscal cliff to the next, and you have incredible changes that are under consideration, and you never know how you can predict in a time of change how to handle many of these things. I think what's the most distressing sometimes in these budget debates that become very political is the whole notion of cutting Medicare and then using it for other purposes. And that, in our view, is completely irresponsible and is something that really has to come to an end. And as we go from one fiscal cliff, or from the Cures bill to the highway bill to you name it, the whole notion, or appropriations caps being cushioned, the whole notion of using Medicare for other things is something that, again, it just cannot be allowed.
I think that's definitely the way beneficiaries value predictability as well, and I think so. We're very much aligned. I think with all providers there that value it. I think the political football nature of Medicare it will continue. It seems it's inevitable to a certain degree. I think a lot of the rhetoric in the '90s, if you remember, around Medicare and Social Security was, we've got to fix this before this demographic wave hits us, and not necessarily because the demographic wave is going to kill the programs, but because there'll be a lot more supporters in those programs, and we won't, have the political wherewithal to change them. So I think we have met that. There's a lot more Medicare beneficiaries. There's 10,000 coming on into the program every day, and they're boomers and they want their Medicare. Now the question will be, what kind of Medicare program are we going to have? But I think we are, and the program is incredibly stable right now financially. So I think we are in have an opportunity to enact some reform, maybe for the longer term. But beneficiaries are going to be very protective of what they have, and I think that's a good sign. I think going forward that maybe Congress will get more bipartisan and come to some agreement, because beneficiaries are going to be there. They're going to force them to do so, and we're not really going to see an end to Medicare as some had predicted.
Yeah, I think predictability is important for physicians as well. Part of the yo-yo dance that we were going through with the SGR was people didn't know whether or not they could make investments in infrastructure, in an accelerator for a radiation oncologist or facilities.
They didn't know if they were going to get paid the next week.
Exactly right. Exactly right. So it made it very difficult. We had 17 go-rounds of that. So it was a little ping-pongy for a while.
Yeah, responsible people on both sides of the aisle are not, nobody's talking about ending Medicare. I mean, we should be clear about that. Responsible people on both sides of the aisle, though maybe not in Congress, but outside of Congress, do talk about making reforms to the Medicare program. It's a program that obviously has its problems. And indeed, Chris is, I think, overly optimistic. Views that, we've got a good, stable program now. We don't have to worry about it. The Medicare Trustees report came out last week. Are
you reading my questions?
I'm just kind of looking through the corner of my eye. And they pointed out that the good news, the depletion date of 2030 for Part A, the general good news that is baked in the cake anyway with Part B and Part D, that all of that is based on the assumption that, for example, the productivity reductions, adjustments, I should say, they're certainly not reductions, but they are payment cuts, and they're basically unrealistic. The actuaries pointed out that in order for the health sector to achieve the same productivity growth as the rest of the economy, you have to have essentially a miracle to occur if you believe that the recent past tells you anything. I think that's a major issue. Is this really a stable program in a financial sense? I'm not so sure. I think whether it's political, whether you consider it political or not, I think the debate over what we're going to do about financing will continue.
Of course, the thing about these projections, with all due respect to the economist, since 1970, the depletion date, as one might refer to it, has been between 2 years and 28 years, I think. So these projections really vary all over the mark, and you've seen it over time.
Can I respond to that? First of all, let's understand there has to be Medicare, because a future without Medicare is unthinkable, particularly for this side of the room, which looks a little bit older to me.
Or how about this side of the room?
Well, they need it too eventually.
So we have to fix it, and groups like this and other groups of thinkers are an important part of that. And I'm not an economist, so I can't argue specifically all the assumptions that went into the Medicare Trustees report. But it is my understanding that none of the potential savings for the alternative payment models, which I hope we get into, none of those potential savings are factored at all.
Right.
I can tell you that in my own particular corner of the world, I'm an orthopedic surgeon, but I just do hand surgery. So my world is from here to here.
So you're not affected by the whole knee hip thing?
No, knees are so last year.
Last week, actually.
It's the decade of the hand. No, but because of some pharmaceutical advances, I am now doing about 80 to 90% of the surgery that I do under local anesthesia. So that means there is no fee for an anesthesiologist, a nurse anesthetist, an EKG, a chest x-ray, lab work, recovery, the IV, all that kind of stuff. So for an operation that, let's say Medicare pays me $400 for, I have about $2,500 in savings. None of that is factored in, and you're talking about 80 to 90% of all of the work that I do, and we keep pushing it. It's safer, we're going to talk about value and quality, I hope. Doing it under local anesthesia is much safer. The diabetics don't have to change their diet or their insulin or anything else. People who are on anticoagulation don't stop it, again, because of pharmaceutical advances. So you don't have to risk getting a stroke or something else to have your carpal tunnel done. These are tremendous advances. This is the sweet spot of quality, satisfaction, the triple aim. And none of that, I think, is factored into the report. So hopefully we'll get into some more of that later.
But that is part of the productivity enhancements, isn't it? Chris is not.
I think it is, but I also think it's true that a lot of savings haven't been factored in. And if you look, you can just go back, and Julie, you'll know this, in recent history. In the 90s, there were projections for a lot less savings than we ended up having. We've seen that in the MMA. We've seen that in many other settings as well. We generally tend to over-project costs and under-project savings, and actuaries do that for very legitimate reasons. You need to plan accordingly. But I think that if any of you have been going out into healthcare systems and hospitals and physicians' offices in the last 10, certainly in the last 5 years, there's definitely a real focus change about how they're delivering healthcare. And I think it's for the positive. Now there's a lot of things we have to do, and I just would like to address something that Joe said, which I'm not drinking Kool-Aid here. I think there are three major challenges facing the Medicare program. I call them the 3 Ds. There's the demographic challenges, there are drug and device challenges, and managing innovation, and the balance of innovation, access, and cost. And then there's the third D, which is really defining, developing, and executing on delivery reform. And doing those three things well, we're going to be fine in terms of sustaining current successes. And if we don't, then we're going to have challenges.
And I agree with that. And I think that, sustainability, I often say, people talk about Medicare sustainability. Well, really nothing's sustainable if we don't sustain it. So the Defense Department doesn't somehow sustain itself. We make a decision to adequately fund it. And so if we've got demographic pressures, we may need more money in the Medicare program because there's more people in it. I think the other thing is that this isn't a Medicare problem. This is a health system problem. So, we have this artificial line between 64 and 65. Other countries don't have that, either if they have national health insurance or other insurance schemes. So we look at Medicare as this program. I often describe Medicare as a program, it's like homeowners insurance where everybody's house burns down. That's why it's a social insurance program. We're all hopefully going to die in very old age under coverage from Medicare. And so I think, looking at sustainability is important. Those 3 Ds are critical problems. We're in an incredible era of change and reform, which is incredibly difficult for providers to navigate right now, but they are, and beneficiaries are as well. So we do have a moment, I think, not to be complacent and say, okay, our problems are solved, forget about it, but rather to say we're doing a lot, and let's see what the implications of this are, what the ramifications are, what the savings are, what the costs are, because maybe it won't work. But it's not hitting a pause button, but I think it is hitting a button to say, let's inculcate some of these lessons before we move off in another extreme direction.
I want to sort of build on a lot of what you all have been talking about, which is sort of the fundamental political fight about long-term sustainability of Medicare is who's going to basically be at risk for increasing healthcare costs. Is it going to be the patients, or is it going to continue to be the government? And if it is the patients, what happens to the people who simply can't afford? I think I mentioned to Senator Wyden, you have all these people who have objectively not nearly enough money saved for retirement. If they suddenly have much higher healthcare costs and can't pay them, are we going to end up with a two-tiered medical system?
Well, I don't think this is an abstract or future problem. I mean, we see it every day in the clients that we help and counsel and represent. You know, the average, you know, around 50% of people have incomes around $23,500 a year, and they're spending 15% on medical costs now. So we don't really see them able to shoulder more risk and more costs. To the extent that they do, they won't be darkening doctors' offices' doors or hospital doors because they won't be able to afford those costs. And so, you know, the access will become an issue. I think there's already shared risk. As I said, you know, they're already paying 15%. They already have a lot of skin in the game. So I think the efforts that we're engaged in now to really provide, you know, better value and the kind of productivity and technological innovations that we're talking about, you know, hold a lot of promise. I mean, that doesn't mean that there don't need to be signals to consumers about certain types of care or other, and consumers, I think, are willing to share the burden of this. But I don't think any proposal that would put significant costs onto consumers across the board would basically, I think, be a terrible thing for folks at the lower middle income and lower income. And just as an example, in the ACA, you have the Magi Medicaid program. We talked a little bit about Medicaid. It goes up to 138% of federal poverty. You turn 65, you're back on age-blind and disabled Medicaid, which, you know, if you're lucky, goes up to 100% of poverty. So you've got this real divide between under 64 and older than 65 about what poverty is and what kind of assistance you can get. We have Medicare savings programs that provide some subsidy for Part B and some cost sharing, but they're very, you know, limited, and they're not well known, and people aren't enrolling them. So I think we do. As we move forward, we need to look at, you know, lower and lower middle income, particularly beneficiaries, and what we can do to help them meet healthcare costs and get access in the future.
But if we're going to sustain this program for another 50 years, I think all stakeholders have to be involved in making contributions. It starts on the revenue side with little tweaks that perhaps could be made to FICA. Little tweaks in the short term add up to a lot over the long haul. I think that we have to look at the whole issue. We talk about artificial lines, the difference between A and B, and Congressman Brady talking earlier about combining A and B and protecting from catastrophic costs. All of that needs to be put in the mix. You took a look at delivery system reform as well, and you heard Senator Wyden talk about better chronic care management. Over 60% of the beneficiaries have multiple chronic conditions, and those people consume 93% of the costs. We could do a lot better in the delivery system. So I think all of these levers need to be pushed as we look toward sustaining it over the next 50 years, regardless of what metric we use to measure its sustainability.
Chairman Brady also mentioned, well, while we're talking about delivery system reform, that he thinks, you know, maybe hospital payment is the next thing up. I lived through the DRG. Yeah, I know. I know it keeps going.
Nobody's contributed more in that regard.
Yes, I know.
I want to take out my violin.
But did you hear what Rick said? No, that's a quote for you. Like it, no.
But what about the idea of, you know, obviously hospitals are, you know, now that we've had sort of we have a broader array of different types of hospitals that do different things. Does it make sense to maybe, and also, you know, merge inpatient and outpatient, give hospitals a different kind of incentive to keep? I mean, it's hardest, I think, on hospitals because the obvious incentive is to not have people use them. Your job is to make your beds empty.
The world is changing. We have a lot of hospitals and hospital systems that are managing Medicare Advantage programs and are involved in managing the care across the whole continuum. We have a lot of hospitals and physicians involved in accountable care organizations and working as partners in organizing care. It has to be done in teams to create the efficiencies and improve quality in the future. You mentioned just last week or the week before the bundling project that came out for certain orthopedic procedures that we think is an opportunity to better coordinate care to the future. Our concern is that we achieve efficiencies through delivery system reforms that help the patient get better care as opposed to just the ratcheting of provider rates. And that's the pathway to the future. And we're changing in terms of how we provide the care and organize the care.
Right, and Julie, I just want to say that one of the most, usually when you ask the question, will beneficiaries pay more, will providers cut more, whatever, or will we raise revenues, those are the three ways, right? But, I really do believe that, you cannot look at our healthcare system today and see how much money we spend per capita and not believe that there are more efficiencies that can be constrained. It's just impossible. If any of you have a parent who've gone into a system and you've just seen the multiple players and still the lack of communications between all the various different providers and how those are handled, there is a boatload of efficiencies that still can be achieved. That isn't to say that you can double the population of seniors from 40 to 80 million from 2008 to 2040 and say, oh, that's not going to cost more. No matter how efficient one can become, those are going to be real challenges. But I would urge everyone who are focusing on Medicare to focus not so much on aggregate costs, but on per capita costs, on per beneficiary costs, not on how much we're paying for the Medicare program, because the challenge is, can we deliver efficient, affordable care for every beneficiary we serve? We can't deal with the challenge that we're going to have 80 million. We can't say, sorry, 40 million of you can't come. It just means that we have to do it more efficiently. And that may require more challenges on cost sharing and outside financing, et cetera. And I think we'd be fooling ourselves if we didn't say that that was the case. But let's not leave out the efficiency.
You just took my talking point this time in terms of that metric. The other thing I think that's the beneficiary talking point. But the other thing that I always keep in front of me is what I keep in my pocket, and this is my mother's 92-year-old Medicare beneficiary, and it's the list of the 9 medications she takes every day and the 15 different doctors that she has and their phone numbers, none of whom talk to one another to coordinate any of this.
I have the same thing. My mother's 87.
I think that's the real challenge for the future.
Exactly, and I think that's what beneficiaries feel as well. I mean, they want that value in healthcare, and they're looking for it. And frankly, they'd be willing to pay a little bit more to get it in some instances. But I agree with Chris that efficiencies are definitely what beneficiaries are looking for, not necessarily for money savings for them or the program, but because they want to feel like the system is really responding to their needs. And I think in this landscape that's changing so rapidly, a lot of beneficiaries are confused about kind of who's got their back or who's on their side. So as we see consolidation in the healthcare industry, when you see ACOs and a lot of what hospitals working with insurance companies can create a lot of efficiencies and a lot of good things, consumers are wondering like, oh, okay, but who can I rely upon as a good navigator for this program? And so I think we need to think about that as well as we think about beneficiary empowerment and consumer empowerment. I mean, at the end of the day, consumers want to turn to their doctor and have faith in that individual, as they have had, that I'm going to be guided through this system. And so I think doctors and hospitals working together are really still going to be the place where they want to place their trust and want to know that they're going to be taken care of. And especially those who are vulnerable and sicker, talking about empowerment and more choice and more options for folks is great for maybe 65-year-olds and 66-year-olds. It's not really what 97-year-olds are looking for. They're really looking for that core trust and faith and value of being taken care of and well monitored.
Dr. I want you to answer this question, but first we're going to go to audience questions in just a couple of minutes. So if you have a question for the panel, microphone over there, microphone over there. Doctors are in a sort of different place here with delivery system reform, that really literally being asked to play a different role rather than be sort of the Lone Ranger, be the quarterback of the team. Is that the direction that the healthcare system needs to move? And how do you sort of get doctors to change mindsets that many of them have had for an awfully long time?
Well, I think doctors are used to adapting to changes in the environment all the time. Remember that when I graduated from medical school, 2/3 of the drugs that we're using weren't available. So we're used to trying to keep up. I think that the place of physicians in the cost-benefit paradigm that we were just talking about, what we can do is to help bend the curve. It was mentioned earlier that 93% of Medicare expenditures are on chronic diseases. Well, what we're doing is trying to address those chronic diseases, specifically hypertension, cardiovascular disease, and diabetes, not only in the Medicare population, but across the population. There are 86 million people in this country who are pre-diabetic and don't know it. So there's a big push now to get that word out, to treat hypertension, cardiovascular disease appropriately early on so that it doesn't become the disease burden. And as we all age, we want to age healthy and have active lifestyles. You can't do that if you have a disease burden. So that's where docs are. Some of the specific things I mentioned earlier in my practice, but in generally, improving health outcomes is I think, the biggest contribution that docs can make from this. One more comment. I know Joe's itching to talk, but the other frustration about your mother's 15 doctors is that their 15 electronic health records don't talk to one another.
Exactly. We got that.
Yes, I know this from my 87-year-old mother. It's like, if I have to fill out one of those things one more time, it's like, can't you get it from the other one?
And when they refer to me, the meaningful use says that they have to transmit the entire medical record. So I have to go through 75 pages off my fax machine that says, hand hurts, go to Gurman. Thank you for that.
So this question about efficiency, we should be clear. There's been plenty of efficiency improvements in the health sector since, well, maybe not since 1965, we don't really know, but certainly since the early days of the Medicare program, partly caused by the fact that Medicare poured an enormous amount of money into the health sector. And this is one of the reasons why the drugs that you're talking about exist.
Well, that's probably more NIH money than Medicare money.
Some of the other sorts of innovations, the imaging and so on, all that's been because of this very large population that now could have the Medicare program pay on their behalf. So there was a huge incentive over the 70s and 80s to create these kinds of innovations. The problem is that we haven't seen them translated into financial savings. We have seen them, as someone said, we have seen them translate into improved health status for patients. But the problem is that the Medicare program, the fee-for-service Medicare program, is not oriented in a way that actually retrieves those savings. It stays in the medical sector. Now, part of it is what we've been talking about, which is the general failure of traditional Medicare to have a coordinated care delivery system. Maybe in a few years, we will see whether ACOs actually accomplish that. But right now, it's a little early to tell. It is certainly the case that these are very small projects. They're very limited results so far. And kind of missing the fact that it's still fundamentally fee-for-service Medicare. Last point, Medicare Advantage. I'm a little surprised that nobody mentioned it, so I guess I will. The Medicare Advantage program is, in fact, if the bidding were set up right, which it is not, but if the bidding were set up right and there was fair bidding, no biases towards Medicare Advantage plans or towards fee-for-service Medicare, then I think what you would see is more capture of those savings that are actually in the system in a responsible way that encourages, let's say, use of services.
Not completely because of the Affordable Care Act. There are larger and larger healthcare organizations, merged insurance companies, merged hospitals, accountable care organizations, hospitals buying practices. How do you see that affecting Medicare?
Well, a lot of hospitals that are building systems of care are doing it for a variety of reasons. Part of it is scale to achieve efficiencies as it relates to a variety of things, whether it's group purchasing, whether it's access to capital, or it's whether for the purposes of trying to improve quality, where putting together these kinds of systems are important. It's also, again, for the purposes of being able to clinically integrate, to coordinate care. So we do see a lot of movement in that regard. But again, I think from the hospital perspective, the focus really has been on better care and improving health through these different organized approaches.
Well, First of all, I'd say if you look at consolidation trends, we've seen, as you point out, pre and post ACA, but I think certainly very recently we've seen a lot more in terms of health systems and health plans. And I think a little bit the jury is out to see the trend line. Now, I think one other reason that they consolidate, of course, is so they can leverage better prices from the payers. And that's increasingly raising concerns with the business community, consumers, governments, et cetera.
For insurers that are already totally concentrated.
And conversely, I was going to get there, or in the health plan community. And there will be, I think, a lot of scrutiny of the health plans to make sure that there's real competitions within those marketplaces. As for the impact on Medicare, really, it's like everything. Everything that Medicare is affected by and it impacts on is affected throughout the whole healthcare delivery system. I think in some ways Medicare is a little bit more protected than other entities, other purchasers are, which is why the business community is even more concerned about some of these consolidations than I think some of the, I would say some of the policymakers following the Medicare program.
I think one of the other issues really has to do with who ultimately pays the bills. And so Medicare is a big payer, but let's not forget that there are millions of people who are have insurance through under 65 coverage. And so that raises another interesting and complicated question, which is how are the prices set? How do hospitals set their prices? We do have plenty of evidence that indicates that because Medicare is essentially fixing prices, that there's some spillover effect on the prices that are charged to the under 65 population. So this is not just a Medicare question, it's a big issue. The argument that some people make that that insurance companies need to consolidate so that they can get more leverage on big healthcare providers, typically hospitals. Yeah, that's one argument. The argument that hospitals have to consolidate because they have to get a certain amount of leverage over the insurers, and there are all these requirements, electronic medical records being a big one. Those are all true. But that doesn't tell you which way it's going to go. I think there's real risk for the taxpayer and for the patient in terms of the kinds of prices they're going to be seeing in the future until we get a more sensible financing system for Medicare.
But just keep in mind, again, for physicians and hospitals, many of whom have over half of their revenue stream from Medicare, Medicaid combined, not to mention uncompensated care, it's not a price, it's a rate. We're given a rate.
Right. The government sets your price. To an economist, a rate is a price. But at least as far as hospitals are concerned, they negotiate, allegedly, with the big insurers. They set a rate that is often related to Medicare, but with a multiple above 1, clearly.
And then, of course, that's to compensate for the fact that under Medicare, as glorious as it is, we're paid roughly 12% below our cost, not to mention what Medicaid is.
Yeah. Well, different people will have different views on that, but let's just leave it there.
Yeah, the word cost is a difficult
Well, I think
term.
on the beneficiary side, with consolidation, I think where consumers are looking is if this consolidation leads to integration of care, because a lot of the consolidation is bringing in doctors and post-acute care into a hospital system, et cetera, that seems to be a very good thing. And certainly concerned about a consolidation in either the insurance industry or the healthcare industry as affecting prices of folks pay is certainly something of concern. The other thing that beneficiaries, I think certainly Medicare beneficiaries, if you look at polling and you look at other pieces of information about how people stick with one plan even though it's not the best plan for them, is that they really are looking for more meaningful choices. And so to the extent that we might cut down some of the number of plans offered to folks, to some that really have meaningful differences. That kind of consolidation would be, I think, helpful to consumers. But certainly we don't know what the impact of some of the consolidation out there will be. But to the extent that it is making things simpler and it's making things more integrated, that's certainly a good thing.
We're basically out of time, but I want to ask one more question, so I'm going to ask for a yes or no answer. Between Medicare's 50th birthday and its 100th birthday, are we ever going to see Medicare extended to the entire population? Chris?
Oh, God, you had to start with me.
You're at the end.
We could do a lot worse. And I think the Medicare program will always be the primary focal point of innovation. You will always see that in this system because the business community will ask for them to lead, and then they will follow. And I think if you're smart about and interested in where the healthcare delivery system's going writ large, follow Medicare.
She said yes or no. I'm going to say no.
Oh, and one more thing.
No. Yes or no?
I would say yes in a shorter way than Chris, and that is that Medicare is asked to take the tough political choices like PPS, et cetera. And so I think it'll always be there, and I think we'll see more consolidation and more insurance plans a lot like each other, whether it's Medicare or the private system.
No, and you'll have to invite me back to find out why I think.
Okay, we can do that. Joe?
Well, of course, the
Well, I've never seen you speechless.
Just staring at me.
Of course.
yeah. So yeah, exactly right. The
Easy for
You can
to
just say yes or no.
yeah, they're going to be. All right, I'll let you do it. Yeah.
Yes or no?
Yeah.
You could say maybe.
Yeah, I think that as a matter of fact, this is something that will not be Jesus has yeah. Well,
Maybe not Medicare in its current form.
Yeah, okay, that's
I
fine.
think I knew where you were going. All right, anyway, thank our panel very much for a wonderful discussion.
Thank you.
And I think we have some closing comments.
Please welcome back Johanna Derlega, Senior Vice President of National Journal.
Thank you so much to Julie Rovner for moderating today, our speakers, our panelists, and you. A very special thanks to the Better Medicare Alliance. And if you could just fill out that survey on the app, we would greatly appreciate it. Have a great rest of your morning.